Medurstand-Understanding Medicine.
Professor Aziz Rehman here. These days we are having a lecture series on Introduction to Clinical Medicine, and this is the second in the series. And let me first present the recap of the last one. Medicine is an art based on science, and it is actually a problem-solving game. Patient comes with a problem and we have to find the solution, and for the solution we need to make a diagnosis, and we need three sources of information, that is history, which patient tells us, physical examination, the finding which we pick up on examination, and then we use laboratory and imaging to reach the final diagnosis. And diagnosis is initially provisional, that means it requires confirmation, and we also develop differential diagnosis because often we're not exactly 100% sure and we do consider other possibilities, and then we reach the definite diagnosis. And as I emphasize, you should always ask yourself, could it be something else, because you don't want to miss anything. And then initial treatment is symptomatic, and once you reach the definitive diagnosis, then we offer definitive treatment, which I said could be just a prescription or hospitalization or an operation or referral to another colleague, or maybe just reassurance. Now today we'll take up this history. What is history? And you must have, I'm sure you have read about it, but let me give you my view. The first step in history is greeting and introduction. And that could mean you approach the patient when you make a ward round, or patient approaches you when patient comes to you or to the OPD. And of course, handshake is not always necessary and appropriate, but whenever possible, that is, I think, best way of greeting. Then there are certain components of history, and first of all is personal profile. Now this means that you have to jot down the patient's name and age and everything so that you know to which person this history belongs. And then presenting symptoms. By definition, symptom is something that patient complains, and presenting symptoms are those with which patient has come for your help. Although when you take history, patient may have additional symptoms, but first we have to focus on presenting symptoms. And history of present illness, once you have listed presenting symptom, which may be just one or two or three, and then you go to the history of present illness. This is actually description of these presenting symptoms one by one in the form of paragraphs. Then systemic review, that means, or it is also called systemic inquiry. Once you are done with the history, patient must have described whatever his or her problem was, but then just to make sure that you don't miss on anything, you just keep asking the patient if there's anything else. So apparently the system which is affected, that is covered in the history of present illness, but other areas should be covered by asking different questions to complete the history. And then past history is important. Whatever medically significant has happened in the past, it could be related to previous operations, previous hospitalization, and any previous illnesses, all I think are important here. And then family history, and I'm going to go into the details of all these later, but just here, I mean, family history, if there is any similar illness in the family, brothers, sisters, siblings, parents, cousins, uncles, aunties, so I think that is important. Then social history, a patient's personal habits related to his eating or drinking behaviors and other, I think, social status, that is also important. Now, drug history has become very, very important because unfortunately, abuse of drugs has become very common, and this would cover all types of drugs. I think I will discuss in detail later. Then allergies and adverse drug reaction. I think nothing is more important to know down if somebody has allergies. If somebody has allergies to a particular drug, I think that must be put somewhere in the record, maybe in red, that you don't prescribe that medicine or something similar to that. Not only allergies, any adverse drug reactions should also be noted. Then I think very, very important, these are relatively new ideas. The patient is actually a human with mind and body. So that person has some ideas, some concerns, some expectations. I think you must give some time to share his ideas and concerns with you so that you can make a proper team. You and the patient make a proper team to tackle the situation and to handle the problem. Now let's take first the personal profile. First of all, most personal is name, exactly the way patient writes, and his or her age. And this is important because we always the illnesses are always concerned with age, gender, address and contact details, date of admission and mode of admission. Whether patient came to the OPD or as emergency, that will give you some information. And I think this has to be noted down either in the chart if you're still using chart, or in the medical records, electronic medical records if you're using electronic medical records. So all these things must be added. I think these days WhatsApp number and email, I think that should also be probably added, because these days we communicate with the people with those media. Now, what are the presenting symptoms? The symptom or symptoms for which patient has come to you. The example is when somebody has high grade fever for 3-4 days. I'll give you some examples. And when you ask patient, then patient will keep describing additional problem like shortness of breath or cough or chest pain. So I think those symptoms may be described in history of present illness. Whatever has brought the patient to you, those are presenting symptoms. I think the presenting symptoms should not be too many. There is no definite maximum number, but I guess maximum 4 should be more than enough. Maybe 1, 2, 3, but not too many. And just include the name of the symptom and its duration in this segment. Like for example, chest pain, 4 hours. I think you may add one adjective before the chest pain like severe chest pain, but do not include mini history here, because that is going to be covered in the next section, that is history of present illness. Then these symptoms should be put in the order of descending chronological order. For example, the symptom of longest duration should be listed first, and then at the end should be the one with the shortest duration. Why so? Because that would actually reflect the way that the condition developed. And you are also going to describe these symptoms one by one in the form of paragraphs, and only then the story will make some sense. And these, I think, symptoms should be listed in layman's language. You should avoid using technical terms, because technical terms have got specific meaning. If you, for example, say hemoptysis, it has got a specific meaning. I think you should use a layman's word like patient spitted out blood, like that. And jot down in the form of bullets, like I have put these statements in the form of bullets. History, the presenting symptoms should be listed like this: 1, 2, 3, 4, like that. And other symptoms may be covered in the history, in the history of present illness. You should just note down presenting symptoms here, because whenever patient describes his problem and you keep asking if there's anything else, patient would come up with more and more symptoms. All symptoms need not be included in presenting symptom. Here you should restrict to the presenting symptoms only. Other can be described in history of present illness at the end in systemic review. So this is an example: high grade fever 4 days, chest pain 3 days, blood stained sputum 2 days. Okay. So I think in chronological order, 4 days, 3 days, 2 days, and just 3. And I have added one adjective because fever may be low grade, moderate. High grade fever immediately gives you some impression. So I think this would make some sense. So when we go to the next section, we will first describe high grade fever, and then we'll describe chest pain, and then mention about this one. Now this is actually a table. Of course, I'm not going to read through all this, but this is just a sample of how many symptoms there could be. This is many examples, so patient could have. Of course, this is not complete list. Now, history of present illness. After personal profile, you write down presenting symptoms, and then you come to this history of present illness. This is actually description of patient's problem. So this is elaboration on presenting symptoms one by one in the form of paragraphs. It typically starts as patient was in his or her usual state of health till when patient developed this problem, like this. Or it starts like patient is a known diabetic and hypertensive and develop this one, like this. Typically we start it like this. So I think you describe any symptoms in fullest detail. Just taking the example of pain. Pain is a common symptom. So pain could be anywhere. So whatever attribute of pain you can think over should be covered. Now this is the mnemonic Socrates, and now you don't have to follow it, but I'm just giving you an example. If you have somebody with pain, you would like to know the site and the onset and the character of pain, because the pain at the same site could, with different character, could mean different things. Then radiation, if the pain is restricted to one particular area or it goes anywhere else also. Then associated features like chest pain with shortness of breath would mean different thing. Chest pain with difficulty in swallowing would be altogether different. Then timing of the pain, and then exacerbating or relieving factor. Again, giving the example of chest pain, if that pain increases on exertion, that would definitely mean something different than a pain which has got no effect with the walking. So this is, and then severity of pain. I think these are some of the things which you can think of regarding pain. So other symptoms would have different attributes. Okay, so I think whatever symptom patient has and whatever attribute of that symptom you can think of, you should ask. And I think while patient is describing his problem, you should not be writing down. You should listen to the patient, keeping a contact, eye and ear contact. Only then you will be able to get the right information. So another example, fever. First of all, documentation. And fever, many people, they describe having fever but without any documentation. So we're not sure whether it is truly fever or is it just feeling of being unwell or body pains and aches. So I think if fever is documented, that would truly make it a fever. Duration, grade, is it mild, moderate, high? Is it continuous, intermittent, remittent or undulating? Is it associated with rigors or additional symptoms? Like fever with productive cough would mean altogether different thing as compared to fever with dysuria. So associated symptoms are important. So I think these are just two examples. There are so many symptoms, and you need to develop your habit. It should be at your reflex level. When somebody says backache, you should have like a series of questions in your mind, what things you are going to ask or want to know about them. Okay, there are certain rules of history taking. Number one, I think it is basically elaboration on presenting symptom. With the starting sentence that, as I told you, patient was in usual state of health, and then you elaborate on the first symptom and then second and then the third symptom. And timing is important because get most relevant information in limited time. You know, time is always limited. Time is actually the scarcest resource at our disposal. You should make best use of time, and you need to develop expertise to take complete history in minimum possible time. Show empathy and develop a rapport. These are, I think, great tools. This is must have tool for a doctor. empathy is an attitude which you should develop, and you should actually connect with the patient, and you should feel patient's sufferings, and you should understand the gravity, and your body language and your words should support your empathetic attitude and develop a rapport. That means patient should be able to feel comfortable with you and would like to come to you again. This is a rapport. So I think these two are great tools and you can develop during history taking. We're continuing with the rules of history taking. I think we used to say allow the patient or relative to speak out his or her problem. I've said not just allow, encourage the patient, because it is not only in his or her interest, it is in your interest also, because you have to figure out the problem and you need information, and the greatest source of information for problem solving is the patient himself. Either patient is describing his or her problem, or if patient is not in that state, maybe a relative is describing the patient. By your body language and by your words, you should keep encouraging the patient to know more and more. I think that will be very, very reassuring, very, very useful. And gently keep him on the track and encourage. Why so? Because patients tend to drift to some unrelated details. You know what is the relevant, what is linked to the story, and patient may not. So I think you should try to gently keep him on the track, but do not discourage him. You encourage him to keep telling you his story, but keep him on the track. Ask open-ended questions. Avoid leading questions. Now, what are open-ended questions? Like, for example, if you ask what increases the pain, so that is an open-ended question. Now, if I ask then this, like, does the exertion increase the pain? That would be suggestive. So I think if there is a question which suggests its own answer, that could bias patient's opinion, and that could lead to wrong information. So you should avoid asking leading question. Either ask open-ended question or ask multiple option question. Like you could ask, does the pain increase or does the pain reduce after this? So I think like that. So you have given two options. Elaborate as necessary. So I think this is the rules of history taking. And very, very important, maintain interest and eye and ear contact. Only then patient will share his or her story. Like, you should not keep writing like a news reporter does. You should, I think, be conversing with the patient, not just listening. So respect privacy and comfort. When you ask questions, you should be respectful to patient's cultural and social status, his gender. I think very, very important. Don't be judgmental. I think this is extremely important. Don't make judgment on patient's behavior which in your opinion are wrong. If patient smokes or patient drinks or patient takes drugs or patient have some extramarital relationship, you should not be judgmental. You should, and this should be just a piece of information for you to reach the diagnosis. You should not be judgmental at all. I guess you understood what I mean. Now, in systemic review or systemic inquiry, I think in the history of present illness, patient would have covered all the presenting symptoms, and then when you encourage the patient, other relevant symptoms from the same system would also be covered. But then there may be some additional symptoms from another system which patient might not have even mentioned, but they could actually be important and they could actually sometimes lead to the right diagnosis, right? For example, while patient is giving history, he never mentioned about his loss of appetite or loss of sleep. But in systemic review, when you find out this patient has got severe loss of appetite, maybe that will give you the clue to the diagnosis. So I think once the symptoms from the main system are covered in detail, then you should pick up some symptoms, some symptom from every system and ask if patient has got any of those. So I think you have to be very brief. You cannot ask about every possible symptom, but just few symptoms from all the systems in the body, so that you are not missing on anything. Or basically, I think you should ask anything else. You just ask the patient anything else. I think he or she would come up if there is anything else. So then we come to the past history. In past history, any significant past illness, hospitalization, operations, accidents or blood transfusions, etc. Examples: history of joint swelling in the childhood may be actually linked to valvular heart disease. Patient has come with palpitation, dyspnea, and in the past history of joint swelling in the childhood would point toward rheumatic heart disease. Similarly, history of abdominal operation may be linked to intestinal obstruction. History of blood transfusion may be linked to hepatitis. And now let's talk about the family history. Now, family is actually a small group of community and linked with genetics and by habits. So if any significant illness, especially in the first degree relatives, it could be genetic disorder like thalassemia. There may be social component, because all people, they have similar in the family, more or less, not necessarily so, have same kind of eating patterns. Obesity, malnutrition is likely to be common in the family. And communicable diseases, if one family member has got open tuberculosis, another person presenting with fever should also be suspected to have tuberculosis, and if necessary, make a family tree if appropriate. In genetic disorders, I think it's a good habit to make a family tree. I'll just show you an example. Now, this is the example of beta thalassemia. I think typically this is like male and female. The sufferers are red and the carriers are pink. This is how you make a chart, and you also make predictions. And this may not be relevant in most situations. If there is a disorder which is clearly genetic, like thalassemia, I think you should make this chart. Now, after this, let's move on to social history. Now, in social history, smoking, type, amount, present or past, I think this is very, very important. You will be surprised sometime that if you ask a patient if that person is smoker or not, patient will say, no, I don't smoke. But then if you ask next question, have you never smoked? Then you will know that patient was a lifelong smoker. Only recently the patient quit smoking. So also the amount and the type of smoking. Alcohol, total amount of alcohol taken, and different drinks, they have different concentrations. You should have some idea how much alcohol patient is actually consuming. Drugs, types, amounts and route, and occupations, working environment, just not his status, his designation. I think if that person is working in the area where there is a lot of dust or fumes, that will make respiratory illnesses, I think, very relevant. Traveling history, because traveling could mean exposure to multiple infection and other things. And sexual behaviors, I think details of sexual behavior should also be asked. But please note down, these things are very personal and you need to provide a proper confidential environment. And from your body language, you should be empathetic, and it should sound that you are interested in his personal details, because that is going to help to solve the problem. It should not look like that you are interested, you're taking it as a gossip. Drug history, prescription and non-prescription medicine should all be noted down, and dosage, duration and route of administration should be noted down. And I think allergies and adverse drug reaction, make a list and put it in the red at the top of medical record or in the chart, so that you don't accidentally prescribe something which is the same or similar, so patient would develop a drug reaction again. And this is very important: ideas, concerns, and expectations. Ideas, like patient might have an idea of routine investigation. So he is asking you to have a thorough checkup and a routine investigation just to be on sure. Just to be sure, okay? And concerned patient may be concerned about mild breast discomfort because mother had breast cancer. Now, if you, after history and physical examination, I think you should emphasize that this is just benign and that is patient concern, and you should relieve patient's concern rather than going into the detailed workup. Expectation: patient just might be expecting some reassurance. Patient have already know, patient has some problem and all he needs from you is a reassurance. I think that is what you should do. Then other histories or relevant histories in women of menstruating age, menstrual history will be important. In children, growth milestone will be important, and I think children particularly, vaccination will also be important. So that concludes our second module on history. I covered, for example, starting with personal profile, presenting illness, history of present illness, at the end systemic review, then all histories like past history, family history, social history, and personal concerns. So I think after all you have done, then you should write it down. It is not a good habit to write the history while patient is speaking. Of course, during history taking, if there is something important, some term or some date or some fact you want to write it down, it's okay without losing the contact with the patient. But I think you should first listen to the complete story, then write it down. And there is another reason also: the patient is always nervous when you take history, and many times once you become good friend the patient, and when patient will actually change his narrative, and then you know the actual story was slightly different than what you initially thought. Thank you very much. This was the